Welcome to Minute Maths. Now we're going to study enteric fever or typhoid fever. Typhoid fever, it is caused by bacteria Salmonella typhi. So the mode of transmission is fecal-oral route, and regarding few words about the pathogenesis. Okay, after it is absorbed from the intestine, there is a time in which there is bacteremia, and then it settles down in the lymphatics of small intestine as we name it as the Pierce patches. They get swollen, they ulcerate and heal afterwards. So basically, enteric fever, typhoid, the patient comes with fever plus abdominal pain. And then according to the time, there are additional symptoms as well. So we describe it as the weekly change in the symptoms. In the first week, there is fever that has a specific pattern. We call it the step ladder pattern. 1899, then 100, then 101, then 102, then 103. Associated with all the constitutional symptoms, no focus of infection. The constitutional symptoms like headache, myalgias, and as we said, abdominal pain. If we describe abdominal pain in adults is usually associated with constipation, and in children it is associated with diarrhea. Now, why constipation occurs in the cases in adults? Because as we have said that the Pierce patches, they get swollen. So when they get swollen in the area of ileocecal junction, that leads to constipation. So we're done in the first week. The patient comes with a fever that has a step ladder pattern associated with the constitutional symptoms like headache, myalgias, and abdominal pain. That is associated in the adults with constipation and in the children with diarrhea. Next, the second week. In the second week, there is a rash, typical rash that we call it as rose spots on the trunk, and mostly it is visible in patients with a fair skin. Second, very important thing in the second week that occurs along with all the symptoms of constitution, there is palpable spleen, splenomegaly in the second week. Here, no other complications have developed. The patient is toxic, the patient is lethargic, but no other complications have developed. Now we move on to the third week. If the patient still remains untreated, then in third week the complications develop. So the local complications, because the focus is in the intestine, the local complications, these include the perforation of the gut or hemorrhage. And the patient comes to you in the ER with acute abdomen. And then this is an infection, a bacterial infection. So septicemia, bacteremia, disseminated infection in the form of in different organs. It can involve any organ. So it can present with osteomyelitis. It can present with meningitis. And it can present with cholecystitis. These are among the a few of the complications that can develop as far as the septicemia is concerned. Now, if we have suspected that this is a case of enteric fever or typhoid fever, how we will investigate such a patient? Before going to investigation, how we will examine such a patient? The patient, it looks toxic, sick look, patient is febrile. Now we know that when a patient has a fever of 101 degree Fahrenheit, for instance, then the heart rate, there is tachycardia according to the degree of the fever that the patient has. But in the cases of typhoid fever, there is relative bradycardia. Because for every degree rise in centigrade, not Fahrenheit, there's supposed to be 10 beats of the heart rate that are increased. But this is not in this case relative bradycardia. Patient has a fever of 101 and with a pulse of about 88 per minute. And then we can look for the raw spots if the patient has a history of more than 1 week. And then we can look for palpable spleen on a clinical examination. So, how to investigate? We start with the complete blood picture and it shows leukopenia. Decrease WBC count. Usually in bacterial infections the TLC is raised, but this is in this case there is usually leukopenia. Then the investigation of choice in the case of typhoid fever is blood culture. Then we have other battery of tests that are supportive, that can yield the results, but the investigation of choice, this is blood culture. Others might be the urine culture, stool culture, or bone marrow aspirate. Even bone marrow is even positive if the patient is in the 3rd week or if the patient is taking antibiotics. But this is an invasive procedure. We don't tend to use this technique. That's why we go for the blood cultures, urine or stool cultures. There are other tests like duodenal strain test. This is also invasive, that's why not done in routine. We pass a string and keep there into the duodenal for about 1-2 hours. Then we pull it back and then we see that the bacteria is present or not. But the investigation, we start with the CBC to look for the leukopenia and we go for the blood cultures. That's the way we do it. And then which tests that are not helpful at all for the diagnosis are Vidal, that were done before, and the Typhoid. Please remember, these are only the supportive investigations. If you have a positive blood culture, then it can be supported by increased titers of the Vidal test or a positive antibody IgM of Typhoid. But alone, a patient with fever and only Vidal test positive or Typhoid test positive doesn't give the conclusion of a patient having typhoid fever. So these are just supportive investigations. Now, how to treat enteric or typhoid fever? First is the supportive treatment or the symptomatic. The patient is febrile, so antipyretics. If the patient is having nausea, vomiting, then the antiemetic should be prescribed. Soft diet, whatever, no dietary restriction, whatever the patient can take, we advise them to taking. Now, the main thing, backbone of the treatment is antibiotics. That should be given according to the culture sensitivity of a particular region. Now we start with the basic empirical therapy. What we actually do is we send the blood cultures and then start the treatment. Start with, we have three options. From the penicillin group we give ampicillin, or the sulfa group, sulfamethoxazole, combined with trimethoprim. That is usually available in market in the name of Cetran. And the third is ciprofloxacin. That was usually, sometime before, it was called as the drug of choice for enteric fever. But now resistance is being developing against the even ciprofloxacin, so we have other drugs as well. So if the patient is susceptible, you know the susceptibility, you can prescribe one of these three drugs. Then if we know that the patient is resistant, if resistance is proven, then we go for the third generation cephalosporins, or a macrolide, azithromycin. And these third generation cephalosporin or the macrolides, sometimes we combine this. These are for the patients who have no complications. What are the complications? Complications are intestinal perforation, hemorrhage, cholecystitis, osteomyelitis. So a patient, the culture sensitivity shows that the patient is resistant to all these drugs, so we can either start with the third generation cephalosporin like ceftriaxone. We either add azithromycin or we only give them macrolides. And if the patient has complications, then we go for the carbapenems like imipenem or meropenem. Now, what about last thing? What about the duration of therapy? The duration is 2 weeks. Only for the azithromycin it is 5 days. The rest is this. So the bottom line is, in the cases of regarding prescribing the antibiotics, you have to give some empirical therapy until the blood culture report comes, and then you can change the therapy according to the blood cultures. Last is, do we have any what are the preventive measures regarding typhoid fever? Preventive measures, these include hand washing and use of boiled water, and we also have vaccines available. Against the typhoid. One thing, that in some patients, the patients they have they become the chronic carriers. Apart from they are not symptomatic, but they shed or they pass the salmonella in their stools for years and years. So what about how to treat chronic carriers? So there are two options: the drug therapy or the surgical intervention. The drug therapy is usually fluoroquinolones. Either we give norfloxacin 400 milligram, that is orally once daily for 1 month, or we have an option of giving ciprofloxacin 750 milligram for 1 month. And if still the patient is not is passing the salmonella, then the surgical option is cholecystectomy. So this is how we treat a patient of having acute typhoid fever. This is the way we prevent for the future development of this disease, and then how we treat the chronic carriers. Thank you very much.